For those of you on the call that I don't know, my name is Shirley Gerard, and I'm the Associate Dean for Research and Community Partnerships in the College of Nursing. And I'm delighted to be a part of the GWET project. I'm one of the co-directors. And I'd like to take this time to introduce to you our second presenter today, and that's Karlene Lawrence, who is a doctorally prepared nurse practitioner who has a very interesting and eclectic background that she can tell you about, but she is the nurse practitioner who is intimately involved with this project and is another one of the co-directors. And she's going to be talking with us today about preventive healthcare for older adults, which certainly in the time of coronavirus and thinking about the presentation that we just had couldn't be more timely. So Karlene, are you ready?
I am. Oh, okay. I see now. So yes, 1 minute. I just have to get over to Bridge. I wasn't sure how to share here. Can you see my screen?
Yes, Dr. Lawrence.
All right, I'm trying to start the slideshow. Oops. Oh no. Sorry. Hold on. I'll just stop.
Yeah, just put it on slideshow. It should take up the
No, it's taking a little while to load.
Oh, it's still loading? Okay.
I think so. I clicked on slideshow. It's not starting. Okay, what am I not doing here?
I don't know. Can somebody help Karlene?
Try the button on the top right corner. You see there's 70%. There's a
It says normal. Zoom?
no, not that. Go all the way down to the right bottom corner. Next to 72%.
Okay.
You see the link?
Yes.
Not that one.
Not that one.
Next to it.
The little arrows.
Yeah, make it 100%.
No, not that.
That one.
There's the stand. You see the stand?
Yes.
Yeah.
Okay, thank you.
Sure.
All right. So I am doing preventive healthcare for older adults. As Dr. Gerard just introduced me, thank you so much. I am the nurse practitioner in the Department of Geriatric Psychiatry. I am the nurse practitioner on the HRSA Geriatric Workforce Enhancement Grant. The grant is an interprofessional education grant to educate the next generation of providers to care for older adults, specifically in Brooklyn. I do not have any conflicts of interest or financial disclosures. The learning objectives for today is upon completion, listeners or learners will be able to differentiate between a preventative wellness visit and a problem-focused office visit. Also identify the multidimensional factors of wellness, name 3 of the 4 age-friendly healthcare intervention elements, discuss the impact of integrating the 7 dimensions of wellness on patient outcomes, and recall at least 5 or a minimum of 5 recommended adult vaccines or boosters specific for the older adults. This is the age-friendly healthcare initiative that I discussed. It has 4 interventions that's recommended by HRSA and also by the Hartford Foundation to care for a patient. Our first is what matters to the patient, or medication that the patients may be taking, the mentation of the patient, and mobility of the patient. So first of all, when our patients come into our clinics, do we introduce ourselves? And when we do introduce ourselves, how do we introduce ourselves? I am Karlene Lawrence, I am a nurse practitioner, or just start speaking to them about their illness. So we need to describe to them or explain to them, our older adults, what exactly our titles mean. I'm a nurse practitioner, what does that mean? And most people think that means I'm a nurse in practice or a practicing nurse. So There's a medical model. We have MDs, we have DOs, and we have PAs. So our patients are aware what those titles mean or those credentials mean. We have the nursing model, we have NPs, we have RNs. And then a combination of nursing, medical, education, and research. We have the DNP, DNSC, the EDD, and the PhD. And then we have our pharmacists. Ageism. So when we communicate with our patients, good communication is actually something that's learned. It's effective provider-patient communication. It's important in the provision of age-friendly healthcare. The first step, which a lot of us may never have thought about, is to ask a patient how they prefer to be addressed. Do they want to be called Mr., Miss? Do they want to be called by their first name, their last name? Not every patient is the same. So the first step would be just asking them, how would they prefer to be addressed or called? What would they want to be called during the visit? A lot of our patients, because our community is a Caribbean community, there's a lot of patients in our community that have low health literacy, and they have certain beliefs that may be cultural, that they have brought with them and that they bring to the visit. I've had patients that say, I only need to check up when I feel sick. Is this true or false? That's false. Only children need to get immunizations. People who know they are sick die faster. This is a common belief in the Caribbean, that a lot of families will not tell the patient what is wrong with them because they think if the patient knows that it's something that may be terminal or may be fatal, they will die faster. I should only take medications a doctor prescribed until I feel better. So a patient will take antibiotics in particular until whatever they were complaining about or got prescribed for goes away, but they will not finish the entire course of the antibiotics. The doctor or nurse is fat shaming me if he or she says I'm overweight or need to lose weight. People who eat healthy don't get sick. So a lot of my patients will tell me, I eat what I like, I'm gonna keep eating what I like because I'm not sick. As long as I'm not sick, then I'm healthy. Females, women, attend more preventative healthcare visits than males. This is actually true. If I feel healthy, then I am healthy. A preventive health and wellness lifestyle is difficult and expensive. A lot of healthy foods are more expensive than the fast food or the easy to get foods that are not as nutritious. So a lot of people will not eat, or they will not go to the farmer's market because they cannot afford it. And they feel that eating healthy is actually very expensive. And the doctors and nurses are responsible for my health. So coming from the Caribbean, where the doctors and nurses are actually, I don't want to say this, but I guess it is like God. Whatever you tell them, whatever you say to them, whatever you decree to them or try to educate them about, they will listen to you no matter what. They will not question. A lot of Caribbeans are very passive in their healthcare. Because they have low health literacy and they really don't understand what we're saying to them, so they will take whatever we say and run with it. This is a wellness wheel. So we're trying to have our patients come for annual wellness exams, not only for problem-focused care. So when they come into our practice, it's not because my head hurts or I feel dizzy and I'm about to pass out. You're coming in, even if you feel well, just to have checkups, have blood tests, speak with your provider, get to know your provider gets to know you, delve into more than just your physical health, get to know you as a person, know your family, what's happening with you and your family. So these are annual wellness visits. And the wellness wheel has certain multidimensional factors that are interconnected and interrelated towards the optimum health of our patients. Wellness is more than physical health, exercise, or nutrition. Wellness is proactive, preventive, and driven by self-responsibility. Each dimension, each of the sections contributes to an individual's self of wellness, quality of life, and affects overlaps with the others. Alternating one dimension may be more prominent than the other, but it changes back and forth. This is not static. Most insurance companies will pay for, without any copay, a wellness exam once a year. It's prevention. This is where we have more time to speak with the patients. Risk factors to screen for and hopefully prevent illnesses or diseases that may be happening. And when you screen and catch or identify a disease early in the process, it's more treatable and the outcomes are better. So this is what an annual wellness exam is. It's a physical, some of the risk factors that are identified at the annual wellness visit is physical inactivity or sedentary lifestyle. And these risk factors that I'm going to list right now appear as the starting point of so many illnesses, not just one illness that may be impacted by this, but a lot of illnesses start with these few risk factors. Physical inactivity or a sedentary lifestyle, having hypertension, which is high blood pressure, or taking medications for high blood pressure, a history of cardiovascular disease, having hyperlipidemia or high cholesterol, or a high triglyceride level, having previously elevated hemoglobin A1C, which is a blood test to see how well you've controlled your diabetes, your glucose over the last couple months, having other conditions associated with insulin resistance, including severe obesity. So these risk factors are also screened for at the annual wellness visit. The annual wellness visits, there has benefits. Some of the benefits, I should go with some of the disadvantages first, because a lot of healthcare providers actually do not like to offer the wellness visit. They think it's a waste of time because it takes more time with the patient. And also some of the articles that I've came across in the literature is that the providers push screenings and tests that they normally would not do at a problem-focused visit. So a lot of providers do not like to have annual wellness visits. So these are the components that starts annual wellness visit. It looks like any other visit, but more comprehensive. So we have the history of the physical, going all the way through the functional ability of the patient. We go over polypharmacy, which is two at least so far of the 4 elements in the 4 M's that we find that's important to offer age-friendly care. Nutrition, we go over gastrointestinal and GU assessments, musculoskeletal, balance, gait, fall prevention, and all the others that are listed on the right side. So it's a more in-depth, comprehensive visit, the annual wellness visit. So that's why the reason why a lot of providers do not like to offer it, because it does take more time. At the general health and wellness exam, which is what we're calling it, we still do blood pressure, weight, and height. For adults age 65 and older, it's recommended every 1 to 2 years. Blood tests and urine tests are for adults 50 to 65 years and older. It's once every year. And lipid screen for high cholesterol or hypercholesterolemia is recommended from age 20 and over every 2 to 3 years. The second part or third part of the annual wellness visit is going into the psychosocial aspects of the patient's life and their family life. How are they sleeping? If you come in and you say, my head hurts, or I broke my toe, or you're bleeding profusely, I would not ask you how you're sleeping on a regular day. But we get to go into the psychosocial aspects of the person's life and their family life. Their mental health. What exactly is happening with them? Are they depressed? Are they having problems at work? Are they are having problems with their children? So these are the questions that we would ask. Life stressors. What do they do to relax? What's happening in their relationships? Definitely ask about sexual health. Do not assume that because a person is age 65 or older, they're not sexually active. A lot of seniors actually are at risk of contracting sexually transmitted infections because they're not aware, they've not been taught. And from when they were younger, they're not aware that safe sex practices around, or that they're required to use condom testing that's around, required testing, or recommended testing. So do not be ashamed because they look like your grandmother or they may be your mother to ask about their sexual health, because a lot of seniors are sexually active. And as mentioned before, employment and finances, family dynamics. Are they at risk of sexual and or domestic abuse and violence? Are they being neglected by their family? Is someone taking their money? Is someone abusing them at home? Their emotional, verbal, and physical health. Eating disorders, this is where you would pick up on eating disorders. Ask the person about their, not just are you eating, did you lose weight or gain weight, but actually what are you eating? What's your breakfast like? Go do a diet recall with them. And are they abusing laxatives? A lot of seniors, I know in our community, believe that as you get older, you should have a bowel movement every day. And if they don't have a bowel movement every day, if that was never their norm, they will start abusing or using laxatives to make that happen. So review that with them. How are they, what's their bowel movement like? How is that happening? Is it because they're using laxatives? One person told me last week she has to drink milk every time she has to go to the bathroom to have a bowel movement. If she doesn't, it doesn't happen. Cigarette, tobacco use, alcohol use, substance abuse, which could be use or abuse, legal or illicit or illegal. Have they been smoking? Are they ready to quit? I think Dr. Shaw had mentioned that. Are they ready to quit? What's their pack per year use? Are they having any effects from that? If they're getting up every morning and they're coughing for half an hour, then they may be having effects of using the cigarettes for a long time. Support system, do they have a support system? Are their families involved? Are their children involved? Are they alone? Are they isolated? Who is their support system? It doesn't have to be a family member. I met one person, just a total stranger, that is their support system, and he's her healthcare proxy. So is it teacher, clergy? Who is the person's support system, if any? Or if they don't have any, why? Or investigate into their lifestyle to see if there could be someone that could be identified to be a support for this person. Coping mechanisms. If they are feeling stressed, what are the stressors? Are they able to cope with it? Do they need our intervention? Is it taking over their lives? Is it affecting their sleep? Is it affecting their eating habits? Are they losing weight uncontrolled? Weight loss that they didn't plan to. So are they gaining weight? Are they eating more because of this? Counseling and referral as indicated. A lot of West Indians, again, a lot of Caribbeans are not into mental health providers use or counseling or being referred to get psychotherapy. So please encourage them to think about that, encourage them to participate because they will get a lot of benefit from it. Brainstorm. So this is, I'd like you to think about the benefits of a wellness exam versus a problem-focused exam, or the disadvantage, which I did mention before, and that's the reason I mentioned them before, of a wellness exam versus a problem-focused exam. So as I mentioned before, from the literature, a lot of providers, a lot of healthcare facilities do not like to do wellness exam because of the time, how long it takes. But the benefits are it builds better relationships between the provider and the patient. Wellness visits can detect and prevent possible illnesses early. And as I said, the earlier detect the illness or possible disease, the better the treatment and hopefully the better the outcome. It identifies possible chronic conditions early, better treatment results and outcome, as I said before, more time for preventive care of the whole patient, and provide healthy lifestyle patient teaching, which is a lot. We don't really always get a lot of time to do patient education with our patients or community residents. Immunizations and vaccines. So the next couple slides could be a little bit overwhelming because there are actually a lot of vaccines that are recommended for the older adults 65 and older. Influenza, which we know about, starts at age 18, goes past 65, 1 dose every year. It can be inactivated, recombinant, or a live vaccine. It is recommended for the senior, especially as the age is recommended to have a vaccine more than before. Tetanus, diphtheria, and pertussis, it's a 1 dose per life, hopefully, immunization, 18 to 65. After 10 years, we get a booster or just a TD, tetanus and diphtheria. Some persons are required to have the Tdap booster again, but the Tdap itself should only be once in a lifetime. And again, it's once every 10 years. I know it hurts a lot, but as I said, you don't have to do it again for another 10 years. MMR, measles, mumps, and rubella, adults born after 1957. The recommendation to get the MMR is from the age 18 to 64 plus years. So if you've never had it, or if your titers are low, it says as indicated, you are recommended to have at least 1 to 2 doses in your lifetime to make sure your titers are up and you're protected. Varicella, chicken pox, again, adults born after 1980 or earlier are advised to have, starting at age 18 to 49 years, to have 2 doses 4 to 8 weeks apart. Varicella zoster, which we know comes around again. Once you have the chicken pox, it could come back again as a zoster. That is recommended from age 50 to or older, and 2 doses are recommended of the recombinant or 1 dose of the live vaccine. I'm sorry, I mixed that up. And the herpes shingles vaccine, herpes zoster shingles vaccine is recommended age 50 to 65 years, and there's 2 doses of that, 4 weeks to 6 months apart. Hepatitis A, 2 doses, 16 to 18 months apart, depending on the vaccine type. Hepatitis B, 2 or 3 doses, 4 weeks to 6 months apart. And having taken the 3 doses, my titers are still low. There's now also a booster for the hepatitis B vaccine. Pneumococcal vaccine, I think Dr. Chow also mentioned that. There's an update on this in the literature. Starting at age 65, you get 1 dose of the PPC13, or if you get the PPSV23, it's 1 dose if you've never received it before. And that's starting from age 65 and older. The pneumococcal meningitis vaccine, a lot of persons think this is a vaccine for mostly college students or for younger persons going into college, but it's also recommended for us, 1 or 2 doses or a booster every 5 years as indicated. Hemophilus B, also, especially for persons that are asplenic, 1 doses for sickle cell or 3 doses if you've had a transplant. What the update is that the US FDA has approved the first quadrivalent influenza vaccine. And so the adjuvant is an ingredient that's added to the vaccine to boost its potency. And this is the first quadrivalent. It covers 4 strains of the influenza virus. The vaccines that we're usually using are that we had before. Sure. Okay. All right. Mm-hmm. Mm-hmm. So most people do not remember what they've had. So there's a vaccine record. So that's another good advantage, a benefit of coming to the annual wellness visit. That record gets reviewed with the patient by the provider as to what they've had before, what is due, and hopefully you could also receive it at that annual wellness visit. Okay. And The last, as I said, the usual influenza vaccines that we've had are trivalent, so they've been covering over 3 strains of the influenza virus, but this new one, the quadrivalent, should be available for this influenza season and covers 4 strains, 2 influenza A viruses and 2 influenza B viruses. And I think Dr. Chow also mentioned this new vaccine that's recommended for adults age 65 and over, for patients that do not have any of these conditions before. They're not immunocompromised, no cerebrospinal fluid leak, no cochlear implants, and have never received the pneumococcal vaccine, PVC13, before. If it's a decision, as I said, with the family, with your caregiver team, with your interdisciplinary team, and if it's decided that the patient should receive this vaccine, it should be administered first, and then the PBSVC23 at least 1 year later. So this is another, as of January of this year, this is a new option that's been released. The skin, the largest organ of the body, on most adults weighs about 8 pounds. It's about 2 square meters. These are some of the age-related changes that happen in our skin as we get older, just living in, it doesn't have to be age-related, but as we're dealing with adults at 65 and older, this is some of the stuff that happens. Most notably, dryness, itching, flaking, warts, boils, and blisters. We could have contact or allergic dermatitis. There is no specific screening test for skin illness, skin maladies. This would be a problem-focused visit. I come in because I have X happening with me. The number one skin condition that we're all mostly concerned about is the prevention of skin cancer. Again, there really is not a recommended test for this. It's more prevention. So there are preventative factors out there, especially for persons that are high risk and for persons that have skin cancer risk, as noted here. Hair and scalp, again, no specific testing for this, but these are some of the conditions that affect our hair and scalp. The brain, again, is a problem-focused exam that would you would come in with a condition or a complaint, and based on that, then your provider would decide what test would be needed or what exam would be needed. Sorry, we go back one slide. So skin cancer is an emerging clinical issue. As far as this is stated by the geriatric oncologist for the older, especially Caucasian population, with a steady increase over the last 20 years, which increase morbidity and mortality and medical costs. The global increase in the incidence of skin cancer during the last 2 decades has reached an epidemic proportion, resulting in long lifetime exposure. This is because of long lifetime exposure of the individual, or on the individual, or by the individual. The eyes, these are some of the age-related or not even age-related, just changes that happen in the eyes. And also another thing that why we recommend, which I'm going to cover in the next slide, regular eye exam, is that signs and symptoms of diabetes, high blood pressure, and cholesterol are identifiable in eye exams. The eye exams that are recommended are for, I left the adults 20 to 39 years because that's where we should start at 20 years. But if not, by the age of 40, it's recommended that we have a dilated eye exam. Whether you have an illness or not, it's recommended to start at age 40 to have your first dilated eye exam. After that, from age 40 to 55 years, because an older adult is not designated as a person 55 and over, you're recommended to have an exam every 2 to 4 years, whether you have an illness or a diagnosis or not. For at age 55 to 64, it's every 1 to 3 years. And as it goes on, the next dilated eye exam is at 60+ years. And then you have one every 2 years. As I mentioned before, the eyes also indicate if you have illness from diagnosis in high blood pressure and diabetes shows up in the eyes. And it's for persons with diabetes or high blood pressure, especially adult diabetics are recommended to have a dilated eye exam every year, and hypertensive or persons with high blood pressure are recommended to have a dilated eye exam every 1 to 2 years. Our ears, again, age-related or regular changes that happen with the ears, and the exam, the recommended screenings or for ears or tests are starting again at age 40 to 49 years is every 3 to 5 years. Age 40 to 64 years is every 2 to 4 years, and if adults or older population, age 65 and over, is every 1 to 2 years, unless there's any other illness, episodic illness that happens. Then definitely come in. They should come in earlier and have a problem-focused exam. No recommended screening for the nose, but these are different disorders that could happen with our nose or nasal passages. Sorry. The mouth, again, age-related changes. The American Dental Association recommends at least a dental exam, screening and cleaning at least every 6 months. At these screening and cleaning, they recommend that the orthodontist or dentist also check for periodontal disease, which happens as we age or increases as we age. Disorders of the neck, most notably thyroid. For us, the screening to prevention, this is one of the few screenings that actually are offered for the disorders of the neck, is at age 30 to 65 years. Is a thyroid test for adults age 30 to 65 and over, is a thyroid blood test every 5 years. But I think most annual wellness visits, when you come in, you have a full panel, including thyroid function tests at least once every year. The chest, which is structures of the chest, these are the different diagnoses that's found in the chest, but most notably for males and females is breast cancer screening. Monthly breast exam for males and females starting at age 18 and continuing through. Mammograms starting at age 50. This is going back and forth between the different healthcare or certifying bodies. I think American Cancer Society has decreased it to maybe 40 now, but by at least 50, between 50 to 75 years, it's recommended that females have a screening, have a mammogram at least every 2 years. Some of the certifying bodies also say every year, but I think most of the providers are going with every 2 years. You have sonograms and mammograms before age 50 if you have a personal or family history of breast cancer. As I said before, breast cancer is for males and females. This is exactly how females perform their monthly self-breast exam, which is recommended. Males should also do a monthly self-breast exam starting at age 18. And as I mentioned before, mammograms age 50 for females, and sonograms, if they're happening before 50 years old, are recommended before 50 years old with a family history or personal history of breast cancer. Oops, I read in 2 places, sorry. The lungs are respiratory, again, is based on problem focus. If there's no, except for tuberculosis, there is not a recommended screening test for issues of the lungs or for respiratory issues. Also, we should assess our patients for use of tobacco, use of illicit substances, especially substances that are smoked like marijuana, and also for use of vaping if they're still vaping at this point, and encourage them for smoking cessation. New York City was, I think they still are, offering free patches to help patients to stop smoking or use of tobacco. And also when we assess patients, we should not assume that it's only cigarettes. There's also cigars and pipes that patients do use. As far as the heart, I'm sorry, those are the conditions of the chest that pertain to cardiology. The conditions of the heart, the American Heart Association recommends checking blood pressure at every health visit. Adults with an elevated blood pressure should have their blood pressure checked again, or have been diagnosed with hypertension or high blood pressure, should have their blood pressures checked every 6 to 12 months, especially if they're on medications. And adults with a normal pressure can have their blood pressure checked at least once every 1 to 2 years. And they should have an EKG when they're first diagnosed and repeat every 1 to 2 years, depending on if their blood pressure results are controlled or uncontrolled. Obesity, which affects so many different areas of the body, is based on obtaining the BMI, calculating the BMI, which we know to do as medical providers. And obesity and combined with diabetes leads to so many other illnesses and diseases in the body. So if you've noticed throughout all of my different sections, I always have the effects of diabetes because it affects so many different systems in our body. The certifying organizations recommend that we adults be screened. The American Diabetes Association, U.S. Preventive Task Force recommend that all persons 45 or older with or without symptoms be screened for obesity or for at every visit. They also should be screened for diabetes at every visit, because a third of adults in the U.S. is obese, and according to the CDC, this has increased also over the past 20 years. My technology is failing me. The American Association of Clinical Endocrinologists also recommends diabetes screening for, as I said, symptomatic person or persons at risk. So being overweight, having a high body mass index, and also persons on antipsychotic therapy for schizophrenia or diagnosed with severe bipolar disease. The liver and pancreas I put together because the diseases are, the illnesses are the issues that affect the liver and pancreas are related. And again, in the middle of all of that is the effect of diabetes, with the exception of trauma and cancers, diabetes affects all these different systems of the body. There's not a recommended test for the liver unless it's, again, problem focused. The colon, the recommended screening for colon cancer is a colonoscopy starting at age 50. Again, this has changed. I think, again, the American Cancer Society has lowered their colon cancer screening risk to start at age 45. And also, we may have heard that African Americans are at higher risk of having once they're diagnosed with colon cancer, to having it progress faster and having it at a more advanced stage. So we're also recommended to start screening earlier. And also persons with a family history of colon cancer are advised to start screening 10 years before that diagnosis was made in their relative. And follow-up after that is determined on what is found at the colonoscopy. If there are no polyps or no adenomas found, then the recommended follow-up after colonoscopy is every 10 years. And the worst part is the prep. No, again, recommended screening for the anus or rectum, but these are some of the conditions that affect the anus and rectum, including sexually transmitted infections. So another thing to screen our patients for is having anal sex and possibly having infections of the anus and rectum. The male urogenital conditions are listed here. it's recommended that males have conduct a monthly self-exam of their testicles starting at age 50 to 49. I'm not sure why it stops at 49. I think it should continue into our older population. That's why I left it here. Prostate digital rectal exam by a provider, and PSA blood test is recommended every 2 to 4 years. And high-risk prostate screen, age 40 to 45 years. So high risk would be a family history or a prior personal history of prostate cancer. And a low-risk screen is persons as having their first screening test or not had any history is 50 to 69 years. Female urogenital, the cervical cancer screening is number 1 for females. That's recommended to start when the female first becomes sexually active, or age 15 to 28 years, whichever comes first. And that recommendation is to have a complete pap smear with HPV testing every 2 years. A low-risk cervical cancer screen is after 29 years, or if you've had a single partner, and that's a pap smear with HPV testing every 5 years. And it's recommended, or suggested, not really recommended, that you could continue cervical cancer screenings after 3 or more normal results in a row, no abnormal results in 10 years, and no history or family history or personal history of cervical cancer. These disorders of the spine and back, again, no regular recommended screening for the spine or the back, or the upper or lower extremities, again, based on a problem-focused visit, something that you're reporting or complaining about. This is the International Working Group recommendation for screening for a diabetic foot, that persons with diabetes to have their foot exams. I'm putting it here because a lot of patients with diabetes develop peripheral neuropathy, which some are aware of, some are not aware of, and this is to prevent them from having amputations or losing all sensation in their feet. So this is a recommendation of how to screen patients based on their presenting symptoms. I know this is not a preventative test, this is actually a test once something happens or if they come in with a complaint, but I think it was important to put this here also. And the frequency of the testing is based on the provider and the patient as far as what they found on the test and what the patient is reporting to them. Osteoporosis, there are recommendations for females and for males. And as you can see, all of the certifying bodies have different recommendations. Number 5, I think, is the one that best, I guess, expresses what we should be looking for in females. And also looking for fracture risk, and that will be happening in the next 10 years. And that is the decision we should use. That from that result we should use to decide how often we should have patients come in for testing. Postmenopausal women are screened with a DEXA scan, and women, I think, younger than 40 are screened with the bone density testing. So this is actually all you can see in most of the certifying bodies of different or differing or varying recommendations. Osteoporosis testing for males. Also, I think number 5, I think states it best, because number 1, there states that there's not enough evidence to have testing in males in the first place, and it goes back and forth. So I think number 5, the guidelines recommend risk assessment for osteoporosis in older men and a DEXA scan, if depending on what the assessment determines. And I think that's about it. I tried to get it in as soon in the time frame that I had. Any questions or comments? No?
Dr. Lawrence, it looks like we do not have any questions in the chat. Unless someone has questions, you can raise your hand and we will unmute you.
There is one.
This
It's
is
the same
this
one.
is Shirley. I have to go to start another meeting, but thank you, Karlene.
Okay, thank you very much. All right.
And we have a question from Kathleen Bradby.
Yes.
Please.
I don't know if you can hear me. No.
Yes.
Oh, okay. You can hear me, Karlene?
Yes, yes.
Oh, great. First of all, I want to thank you so much. This is excellent. I teach a course to undergraduates on care of the older adult and also to RNs. And I think we tend to take for granted that because we deal with so many older patients, you know, they're just that, versus the true specialty that this has evolved over the years to be. And now, most especially, I'm grateful for the screening emphasis that you have and almost part of the systematic assessment that needs to go on. So these are skills that I feel we have underemphasized in our curricula, and hopefully we will be more correctly emphasizing and incorporating those things, such as what you've shared today. The notion that there is normal aging versus aging and functional loss that can be problematic, I think is an important differentiation, because a lot of people attribute things, just getting older, you know, that's all it is, versus really kind of understanding what may be happening for the person in addition to all of those other psychosocial, familial, and other risk factors in there are important. So I'm babbling to say that this has been excellent, and I feel we need to take a lot of this under greater advisement in preparing our future practitioners.
That is actually the number one thing that came across in review of the literature is not only in the US, but globally, preventive health is not the focus of our healthcare systems right now. It's basically problem focused, and just we need to change our focus to preventive health just because it's more economical, but it's also beneficial to our patients. As I said, I think I said in the beginning, prevention is always better than cure, and it turns out that prevention is actually less expensive than cure right now in the healthcare system. So we need to really change our focus to preventive health, which is disease prevention and maintenance of health.
Right, and the documentation of it, that's the other issue. Sometimes things are documented in the electronic health record, but unless we bring them forth on a regular basis to discuss them or revisit them or further monitor, we've lost it. So it's documented, but we're really not incorporating it into our daily plans of care. So that, I think, is another piece we need to be conscious of.
Thank you.
Thank you.
Esther's asking about recommendations for OBGYN and neurology. So again, from looking in the literature, I think it's problem focused. I did not find any preventative tests, well, except for the cervical cancer screening, which is not OBGYN, but just GYN. And I did not find any urology except for the PSA, the prostate cancer screening. I'm not sure if that is what you were asking. All right, thank you.